We have covered most of the points. We just straight away go for show. sedation, regional anesthesia, TIVA, or general anesthesia. These are all the choices. In monitored anesthesia care, the procedure specialists monitor the patient with the help of their staff. So normally an anesthesiologist is not required because the patient is almost fully conscious with very mild sedation, and he will be able to maintain his airway, and he will be able to respond to the calls also. So that is the monitored anesthesia care. Sedation, it can be classified as conscious sedation. This describes a depressed state of consciousness, but patient will be able to respond to commands, maintain his or her own airway, and airway reflexes are well preserved. Then there is a state of deep sedation. If the consciousness is depressed to the extent protective airway reflexes are obtended and airway maintenance becomes necessary, and this definitely requires the presence of an anesthetist who can put in an airway or give a jaw thrust or maintain the head position properly to maintain a stated airway. And patient can easily drift from the state of conscious sedation into deep sedation depending upon his age and sensitivity to drugs and health status, etc. So titration and adjustment of the drug dosage is very important and requires the skill and expertise of the anesthesiologist. Now, total intravenous anesthesia, the drugs used and some agents are often required to maintain a patent airway. And the airway can be maintained by either chin lift, jaw thrust, or oropharyngeal airway, or LMA can be used in a deeply anesthetized patient. Now, procedure suitable for TIVA are lithotripsy, oocyte retrieval, IVF, and fetal reduction surgeries in ultrasound room. General anesthesia with controlled ventilation is the choice in many situations, particularly the patients are undergoing coiling of cerebral aneurysm, etc. in the radiology suite. And in MRI, you must use an MRI compatible anesthesia machine. Not just MRI safe, but it should be MRI compatible. What is the difference between MRI compatible and MRI safe equipment? Sajita. This is a common question they may ask you if you are talking about MRI. Vidya?
The material of the machine and the body material of the machine is made of non-electromagnetic material.
What is the difference between MRI safe and MRI compatible machines or equipment? MRI safe machines are safe that they will not be attracted by the magnetic field created by MRI, but their functioning status is not guaranteed. It is called MRI safe. Whereas an MRI compatible equipment will not be attracted by the magnetic field and it will function normally. That is called an MRI compatible anesthesia machine or an equipment. So this is a major difference. MRI safe, it will not be attracted by the MRI, but the functioning status, for example, an ECG machine, which is MRI safe, will not give the tracing properly, but it will not be attracted by the MRI magnetic field. Whereas MRI compatible ECG machine or a pulse oximeter will show the normal waveform, normal rate, everything, but it will not be also attracted by the magnetic field. So that is the major difference that you have to remember. So this is how the machine is used. On the regional anesthesia, you can commonly use spinal epidural or combined spinal epidural in remote locations or nerve blocks to a particular limbs wherever required. Coming to the monitoring, these are the minimal monitoring. You must have pulse oximeter, ECG, NABP, end-tidal. In the non-intubated patient, end-tidal CO2 can be monitored by tapping the sampling line to the patient's upper lip near the nostrils. In the expired CO2 is sent along with the graphic display and respiration. Documentation of anesthesia, time and dose, saturation, heart rate, respiratory rate, NIBP, all this can be documented, and level of sedation also to be documented. And when the patient is having a conscious sedation, the interval for documentation is 15 minutes. Whereas if the patient is in deep sedation or general anesthesia, the interval for documentation is every 5 minutes. And commonly used anesthetic agents are midazolam, fentanyl, propofol, ketamine, ketofol, remifentanil, dexmed, and puriloxime. And for lithotripsy, they can use even puriloxime on the surface. Special considerations are anaphylaxis to the dye, which is be aware of. So any contrast, if the surgeon or the radiologist or the cardiologist says I am going to use the dye, make sure that patient does not have any history of allergy, and patient is should be adequately having an IV line to hydrate them so that they don't go in for contrast induced nephropathy. And our hypothermia is the next problem in the Nora, should be avoided. And radiation exposure to both the anesthesia personnel as well as the patient is the third special problem that we have to remember. Post procedure, we have to transport the patient to standard recovery room, accompanied by all the monitors, and the anesthesiologist should accompany for the safe transit. And most patients may require oxygen during support because they may be in a sedated way. And patients who require elective post-op ventilation must be transferred with continuous monitoring. Discharge criteria, these patients are the same as for the patient after surgery. Now, what are the common complications that Nora can produce? There are a host of complications starting from wheezing, coughing, aspiration, desaturation, allergic reaction, apnea, cardiac arrest, hypothermia, luminospasm. So, airway related, cardiovascular related, procedure related, prolongation of anesthesia, secretions, unintended deep level of anesthesia, use of reversal agents which may be unplanned, vomiting, nausea, emergencies. All these things are the complications that are there. And the ASA has prescribed some guidelines in October 2003. It was amended in 2008. So there should be a reliable oxygen source backup, suction source, waste gas scavenging, adequate monitoring, self-inflating hand resuscitated bag, sufficient safe electrical outlet, adequate patient and anesthesia machine illumination with battery powered backup, sufficient space for anesthesia care team, emergency car with defibrillator, emergency drugs, means of reliable two-way communication to request assistance. In compliance of the facility will all applicable to safety and building code. Appropriate post anesthesia management to be provided and adequately trained staff to support the anesthesia care. These are all the guidelines that have been given for safe conduct of anesthesia. Of course, the accessibility to the patient is also one of the problems in MRI, especially when you give MRI for anesthesia for small kids undergoing MRI. You require a special equipment like a long vein circuit or Jackson vein circuit. The machine will be outside the MRI gang 50 gas line. So you require a long circuit. Whenever you have a long circuit, there is always a possibility of disconnection. So before testing the patient inside the MRI suite, you have to make sure that all the connections of the breathing systems are all well fitted and nicely secured. The airway should be taken care of. Right? These are the points that you have to. So you have covered most of them, but you can modify a little bit by including the points that I have shown. That
Yes, sir.
especially the me mnemonic is a accepted thing that you can write in your answers, so that in practice also it will be useful to remember what are all the things that you have to check before you start anesthesia in a remote people. Especially you go out after your degree and start practicing in an endoscopic suit. That is the most challenging job that you come across. So there you have to check all these things before you go. Okay? Yeah. So shall we say see you later?
Thank you,
Yes.
sir.
Thank
Yes,
you.
sir.
Next
Thank
week,
you, sir.
I may not be available because I'm undergoing a small surgery tomorrow. So
Okay.
next week's class will be taken later. So next week I don't think I will do a digital class.
Okay, sir.
Okay, sir.
So I'm back to my routine. I will let you know. And probably from the second week of September, we may resume the class. Two
Yes,
classes
sir.
I will not be able to do.
Okay.
Yes.
Thank you very much.
Thank you, sir.
Thank
Thank
you,
you.
sir.